So my name is Shelby Lancaster. I'm the clinical pharmacist lead here at
Oh, there we go. Okay, we're good.
Thank you. Clinical pharmacist lead here at Family Health Services, and today I'm talking to you about continuous glucose monitoring data and making sense of it in a collaborative diabetes care setting. I don't have any disclosures to report, though I do want you to know I'll be using branded names for CGM devices because the generic names are not available. And I also want to note that I do have some hidden slides that I will not review, but they are present in the presentation that you guys have access to for your learning. Today, we're going to review different types of CGM options, looking at cost and financial resources. I do have a resources page that is available for you guys to access, as there's a lot of websites that you can go to from there. We'll also talk about some CGM billing options, specifically the 95251 billing code. We'll also talk about Family Health Services workflow and really look at the data model for data interpretation for CGMs. We'll review that documentation and talk about a patient case. So I do want to note that this is part one of two. My counterpart, Megan Williams, who's not here today, will be continuing at the next ECHO session, focusing on continuing that conversation and presenting cases. Ultimately, I do want you guys to know that the ADA does have a tiered approach for recommendations for CGM use, looking at treatment intensity, hypoglycemic risks, rather than universal access. But any patient with diabetes who we feel the CGM would be helpful in management of their blood sugars, we should try to get them access to them. There are a few different options with regards to types of CGM devices. I'll really focus on that real-time CGM because it has the continuous updates, the real-time alerts and alarms, and they are the most popular options at this time. And looking at those specifically, we have the Dexcom and the Freestyle Libre, which are ones that are used pretty commonly, at least in our practice. The ADA does have this nice little chart that goes through the different options that are available, provides or what requires prescriptions as well as which one has alarms. With our CGMs, there are pros and cons to these. So ultimately, having access to continuous data is really amazing for pattern identification and management of patients' blood sugars. Having alerts and alarms help our patients with their management and increase their safety or improve their safety. They do allow for data sharing with the ease of access to the clinic as well as from a family perspective for safety and support should they have issues with low blood sugars. This does reduce finger pokes. It does not completely replace them because there still could be issues with CGM monitoring being completely accurate and or failure. So any individual that has a CGM should have access to a blood glucose monitoring device. Some of the cons is it does require setup and education, but with any device that we're using, whether it's a CGM or a blood glucose monitor, it still requires setup and education. Some patients can get tired of those alerts, but the way that we mitigate that is by ensuring that those targets are set up appropriately at the time of placement, and then we update those regularly as we work with those patients. The other con is cost, and this is something that I will address on a later slide. So for our Dexcom devices, there are three available on the market right now, but there is a note that the Dexcom G6 is going to be discontinued in June of this year. They're going to be more and more difficult to get access to, so something for us to be mindful of when we're meeting with our patients to get them transitioned to the 10 or the 15 day. So with these Dexcom sensors, they usually require 20 to 33 feet for the Bluetooth connection, with the 20 feet giving the optimal connection. And with this system, the data is updated every 5 minutes, and those sensors can store data for 24 hours. So if the patients are away from their phone or their receiver for less than 24 hours, once they come in contact, it should upload that data. And as you know, here there's a 10-day versus the 15-day, though they both have that 12-hour grace period to allow for patients to decide when it is best for them to replace. So it doesn't go off in the middle of the night and having to replace a sensor. The warm-up time does differ a little bit between the 10-day and the 15-day, and so does the FDA approval. So with the 15-day, they have the approval for 18 years of age and older, and again on the back upper arm compared to our 10-day for those 2 years of age and older, and you can use the buttocks area to get an appropriate amount of subcutaneous tissue. The Dexcom 15-day does have a slight improvement in accuracy with that mean absolute relative difference, indicating that accuracy. Of course, the lower the number, the better, of 8% versus 8.2% with the 10-day. And then you can see here the pump compatibility. One thing I did want to mention is that it has been reported that the Dexcom G7 does interact with higher doses of Tylenol, or excuse me, of acetaminophen. Specifically greater than 4 grams per day can result in a false high. So something to be mindful of, and hopefully our patients are not having to take that much, but of note. With our Freestyle Libre, they do have the 2 Plus and the 3 Plus. The 2 without the Plus and the 3 without the Plus have been discontinued, and they have moved on to just the Plus systems. A little caveat with the 2 Plus is that it requires 20 feet. It doesn't have as much extension as the 3 Plus. And if you have a compatible phone with the 2 Plus, it will update that data every minute. If you have a scanning reader, you have to scan every 8 hours. And the reason is because it only stores 8 hours worth of data. You don't want to get gaps in your data if the patient is not scanning at those time periods. Otherwise, the data is not as accurate and it's hard to identify patterns. With our 3 Plus, it's nice because it updates that data every minute. It's with a compatible phone or Bluetooth reader, so it's really the distance that we have to be worried about, and it stores that data up to 15 days. So that's really handy if we have patients that are away from their phone or their Bluetooth reader for any period of time. Both of these do last up to 15 days, and the warm-up is the same across the board. The approval for FDA use for the age is the same, and the accuracy was pretty similar with that MARD of 8.2%. And we do show some pump compatibility here. I will note that the Freestyle Libre does interact with vitamin C greater than 1,000 milligrams per day. It can result in a false high. The 2 and the 3 without the plus, so the older generations was 500 or above. So this gives a little bit more leeway for our patients that like their vitamin C. So on to cost. This one here does have information about CGM coverage from an insurance perspective. So if you have Medicare, the coverage can be variable, though if you have 1 injection of insulin per day or you have recurrent level 2 lows, so blood sugars of less than 54 milligrams per deciliter, they will cover the sensor. And I say cover with quotes because it is quite variable. If they have just an A and B plan without a pharmacy plan, this is partial coverage and usually at the DME benefit. So getting patients set up with a DME supplier, we tend to use Advanced Diabetes Supply or Norco. Some of them have hardship forms to allow for them to report their income and help reduce the out-of-pocket costs for them. If the patient does have low income subsidy or LIS, it does cover the majority, if not all of it, and that could be either a DME or an RX benefit. I'm seeing it more pushed towards the pharmacy benefit. And then if they have an Advantage plan, this is a partial coverage, and the pharmacy benefit is where it should be sent. If they have Medicaid, it's a full coverage. And again, the caveat is they have to be on 1 injection of insulin per day, or they have to have recurrent level 2 lows. And this is actively actually a prescription benefit. So they had put out that the RX benefit would be starting the 1st of April, but I did a test claim on the 19th of February and it ended up working. So we have been transitioning all of our patients over to the pharmacy benefit. If they do have a current DME supplier, the DME supplier is transitioning them to a pharmacy benefit that they're connected to. So just be aware of that. If the patient does have commercial coverage, quite variable. Real-time test claims have been really helpful for us in the family health services realm. I know it can be really challenging if you don't have access to a clinical pharmacist that can do those test claims on the back end, but hopefully you have a pharmacy that you work with pretty regularly that could help you out with that. Dexcom does report that they are covered by Blue Cross of Idaho, Regents Blue Shield of Idaho, Aetna, Cigna, and United Healthcare, and Libre has the same with the addition of Humana. So for our cash paying patients, There are, again, this resource page that I want to make sure you guys have access to because of all of the links that are there. But there's one free sensor that can be claimed by patients, and I believe that this is regardless of whether they have insurance or not. But they need to access the manufacturer website. One of the things that we have been really diligent about is getting to know our reps. We have a tremendous number of samples available, so that way we could use them intermittently for patients who really struggle to afford the cost of these sensors. The downside to that is that they do require a compatible phone. But if your reps are nice enough, sometimes they'll give you a couple of receivers to be able to utilize for your patients as kind of a trial patients. Freestyle Libre it does tend to be cost effective. The out-of-pocket cost with a coupon tends to run about $76 a month. One downside I would say is that they do not have an additional financial assistance program like our Dexcom G7s. They do have specifically a financial assistance program for type 1 diabetes patients, but there are certain stipulations, specifically that federal poverty limit for their income has to be less than 400%. Access to this has gotten easier, and same as the application. The caveat with this is it's only a 6 month supply that they'll be providing. So our patients that have type 1 diabetes, it's only going to cover them for half of the year, and then they kind of have to figure out what to do for the rest of the year. And it's not free. It's $45 for a 90-day supply or $90 to cover that 6 month supply. And the coupon that they have really only saves up to a $200, maybe $210 a month. So it brings it down to like 180, and that's pretty high for our patients. So these are some of the options that we have come across within Family Health Services, and hopefully that will be helpful for you as well. The next thing I wanted to cover was the CGM billing codes. So this is something that has been helpful within Family Health Services to provide some reimbursement for reading some of these. Specifically, I'm going to focus on the 95251 code for CGM analysis and interpretation. So with this, it is reimbursed by Medicare and Medicaid up to $40 per billing. It can be performed by a qualified healthcare professional as listed here and can be billed every 30 days by physicians, NPs, or PAs. And it requires a minimum of 72 hours worth of data, though the ADA does recommend 10 to 14 days. And to ensure that you are able to appropriately identify patterns, having a 70% of the time that CGM being active. The other thing that this requires is clinic logins. So you need to have access to LibreView for the Freestyle Libre and Dexcom Clarity for the Dexcom system. But you can have an administrator that has that, and then they can add in people that you need to pull data for or upload data for. This can be billed either in person or over the phone. The downside is if the patient has a receiver, it does require a manual upload, so they'd have to come into the clinic and do it, or they could do it from home if they have the appropriate login. And then a compatible phone allows you to connect to the clinic automatically, so you could see patients' data at any point in time, allowing for that remote download. So within Family Health Services, if a patient with diabetes or a person with diabetes is identified that could benefit from CGM, if either the pharmacist or the diabetes educator is in office, usually a sample CGM will be placed that day through a warm handoff. So we'll provide the education, and then a CGM will be prescribed for the patient to pick up at the pharmacy or through a DME supplier with further education on how to access that. Referrals are then sent to one of the three or all of the three, depending upon the patient and their need. But chronic care management is a nice hub to have because they can help with care coordination. They can help with CGM report cadence and pulling those numbers and sending them to whomever is taking the lead on the CGM analysis and interpretation. And then, of course, our diabetes educator and our clinical pharmacist can provide these resources as well, in addition to the CGM education and interpretation, as noted here. And whoever is taking that lead will check in with the patient or request that the care manager check in with the patient at any given interval, depending upon the need of the patient, but being mindful that we can bill for that 9525 code 9525 code every 30 days. And then we want to make sure that the patient has a follow-up with their PCP every 3 months until they're at goal. And ultimately, between all of us, we kind of share these patients and ensure that they have the support that they need to get them to their goals. With the interpretation of this data, it's really nice to have kind of a stepwise approach. And the data model is really helpful. It's a great interactive model to determine what the patient's been experiencing and what plan works best for the patient. And it was developed by Diana Isaacs, who's a PharmD, and a bunch of other alphabet soup behind her name. So D is data download. We want to look at those key metrics, what the person learned, and how they feel things are going. Then we want to assess for their safety. So identifying any hypoglycemic episodes, looking for those patterns, and having that interactive discussion with them to discuss possible causes and solutions. We also want to review their time in range. So focusing on those positive days where that time in range is the highest. What was helpful during those days, and can we replicate that on a more consistent basis? Then we focus on those areas to improve. So those hyperglycemic episodes that are occurring consistently, we talk about the possible causes, those solutions, and identifying where we can adjust medications or diet to help minimize them. And then come up with an action plan. So develop that plan collaboratively with that person with diabetes and help them be successful. So if you're doing a 95251 using that data model, ultimately you're going to copy and paste that AGP data or the ambulatory glucose profile data to analyze. It includes the days worn, the day analyzed. It looks at all of the time in range, time above range, time below range, in addition to a few other metrics that I'll go over shortly. Then we have the summary of findings that goes in that HPI. So we talk about is the patient time in range? Where is it at with that? Is the coefficient of variation stable or unstable? Is the patient spending time in hypoglycemia, and what patterns are we recognizing? What are they spending a lot of time in high with high blood sugars, and where are those patterns really lying? And ensuring to do a complete diabetes medication reconciliation, because that's going to impact your interpretation and plan moving forward. And then, of course, making sure that you document your plan with those appropriate diagnosis codes. So I have a case here, and the patient is a 57-year-old male with type 2 diabetes. His medications included dapagliflozin 10 milligrams daily, metformin ER 1,000 milligrams, glargine 60 units, and Lispro 7 units 3 times a day. His A1C in November was 10.3%. He did have a history of medication noncompliance that was addressed at that visit in November. His cost is a significant concern for this patient. So luckily we do have Medicare with low income subsidy that reduces the costs of those out of pockets pretty significantly. Though, as you can imagine, if they're paying $60 for a 90-day supply of medications, all of their medications, that's still quite a hit at the beginning of that 3 months. Recent A1C was 7.6%. He was not checking his blood sugars, so he did deny any low blood sugar symptoms. The Freestyle Libre 3 was used in the past, but he had adhesive issues, though he was willing to try an alternative. And ultimately, the goal with the patient was to reduce the injection burden, reduce the number of finger pokes that he would have to do as he's not doing it anyway, and then get that A1C to goal. So at that appointment, the Dexcom was initiated, the 10 days specifically. Tirzepatide 2.5 milligrams weekly was started. His glargine was preemptively reduced secondary to his A1C being less than 8%, and then the same with his Lispro. A chronic care management referral was ordered that time and requested that the data was pulled in approximately 1 week with a follow-up appointment in 4 weeks. So pulling his AGP report, this is what the top half of it looks like. So we see that we have some terminology that's listed here. So the time in range is the time the patient spent with the CGM on between 70 and 180 milligrams per deciliter. It's recommended that is 70 greater than 70%. The time below range, so less than 70 and less than 54. We want those less than 4% and less than 1% respectively. The time above range, greater than 150, greater than 250. We want those less than 25% and less than 5% respectively. That glycemic variability and or the coefficient of variation, we want that to be less than or equal to 36%. The lower the number, the better off we are, as that talks about how, or shows us how, of course, variable those blood sugars are, how high the highs are, how low the lows are, and are we going between those frequently. Um, And then you also have this GMI, which is the estimated A1C from that CGM data. And the reason that that it's recommended that that time in range be greater than 70% because it correlates close to 7% or 6.9% A1C. So with this patient, we can see here that his time in range was 92%. He had 6% in the low category, with 5% being less than 70 and 1% being less than 54. And his very high was 0, high was 2%. So he was in goal with these two metrics here, but then his lows were high. We see that his average glucose was 114, his estimated A1C was a 6%, and coefficient of variation was 26.7%. And of course, his CGM was greater than 70% active at 99.5. So this next graph that we have here is basically an overlap of the data from every single day, like it's happening in one day, so that you can really identify those patterns from a quick look. And as we can see here, that the patient was experiencing quite a few lows, which was represented by his low percentage that we saw here. And then we had some postprandial elevations here in the evening. So below that graph shows this daily glucose profile. So it shows from day to day what's happening so that you can really focus on those specific times, those specific days when things are occurring. So from what we can see here, a patient was having some postprandial spikes. And then as the tirzepatide came on board and started working, his blood sugar started to come down more effectively, really starting to see a little bit of a low here between the 8th and the 9th. On the 10th for sure, the 11th we were having them multiple times, and the 12th we're having quite a few there. So documentation for the 95251 code, I copy and pasted that summary of the AGP in the note that pulls all that information. Patient's time in range is at target. That coefficient of variation showed stable glycemic variability. The time spent in hypoglycemia is above target, and those hypoglycemic patterns were noted fasting and postprandial for the last 3 days. The time spent in hyperglycemia is at target, though even though we weren't seeing consistent patterns in hyperglycemia, we did notice one that post low blood sugar hyperglycemic episode on the 12th. When I did a medication reconciliation on his medications, specifically diabetes medications, he was taking them as instructed, though he did hold his short acting because of the lows. So at that time, we discussed having a plan. Okay, we're going to discontinue that Lispro, reducing his injection burden, which is right on par for our targets and goals, and reducing his glargine an additional 10 units down to 40 units daily, and pull that data again in 1 week. So when we were able to look at it again on the 17th, we can see here that patient had a significant increase in lows. His very high and high were shifted down into the in target range, but we had a number of lows that were occurring. And we can see here on the 12th, then to the 13th, we were still having them. And again, it was just his blood sugars were getting lower and lower with regards to the tirzepatide coming up in the system, and being mindful that this is 2.5 milligrams weekly. So at that check-in, we talked to the patient about reducing that glargine by half down to 20 units daily and pull that data in 1 week. I'd rather the patient run a little bit high than low, and we can always increase the dose of the glargine at that 1 week follow-up. So when we pulled that data approximately 10 days later on the 27th, we can see that his lows did come up and improve significantly. He was within target range 93% of the time, and then the high percent was about 5 there. And as you can see moving forward, that his lows did start to improve and really started to resolve by like in the 23rd forward. And we did start seeing some postprandial spikes that were occurring here. So he did follow up with me today, and I believe that his target range was 96% of the time. His lows were less than 1%, and his highs were 0. Let's see, but sorry, like the 2 or 3, excuse me. So ultimately, we are continuing to titrate the tirzepatide up to the 5 milligram, preemptively reducing the dose of the glargine by an additional 20%, and then hopefully we can discontinue that long-acting insulin. One thing will be of note: it could disqualify him for CGM, but hopefully if we can get him on to the tirzepatide alone without insulin, that we won't need it as much. So key points with this: CGM is a powerful tool, and I think Roger had mentioned this before. It's something that we can use for our patients and help identify those patterns and really make an impact on their medication management. The downside is that affordability. It can be really challenging sometimes to get access to these for your patients. So use your resources. Try to get some samples in stock so you can have intermittent use of the CGMs to get them to target. Use your 95251 billing codes to allow for higher touch points between appointments and get some reimbursement for that. Chronic care management is also a great resource to help track our patients, get what we need when we're requesting it, and then also allow for some reimbursement. The data model is a great model to allow for interactive discussion with our patients, ultimately addressing the lows first, of course, from a safety perspective, and then the highs. Sometimes if patients are having hypoglycemic episodes and then they're overcorrecting, sometimes we can take care of the highs when the lows are addressed. CGM use is becoming more and more common, so it's really important for us within the primary care setting to be able to access this data and know how to read it and use it. There are a lot of free resources for healthcare providers to learn how to do this, and I do have some information on the resources page for you regarding that. I have some references listed here, and do you have any questions?
Shelby, thank you so much. You can stop the share there. So that was fantastic. As she said, she had a very limited amount of time, so she snuck in several other really useful slides as well. Eric, can you put the link in the chat so that people know where to find those slides again? And I know that someone was having problems with seeing the screen. There will be a recording of this also available on our website there.
Yeah, it's really hard to get that data into one location, so I apologize for it being small.
It's great. Shelby, what questions do we have for Shelby today? You can just unmute or put those in the chat. And Matt, can we start with you? You had a question earlier. If you just want to unmute and ask that question.
Yeah, the MARD for can you describe that for us? And the other question that's kind of a tag along with that one is there's some inherent scariness using a CGM if it's telling you real data. Can you tell us what MARD is and how you deal with CMG uncertainty?
Yeah. So the MARD or the MARD is that
Oh,
mean no, you're totally fine. To be honest, I'm calling it MARD because I don't know for sure if you can call it MARD. So we can refer to it either way. So it's the way that they as in the manufacturers have determined their accuracy. I don't know the complete logistics of it, but ultimately, with that 8%, I want to say that it is across the board pretty consistent with those different devices. And ultimately, if you want more information regarding that, Matt, I can definitely get that for you. I don't have it on the top of my head today. But with CGM uncertainty, you're specifically stating from a like accuracy perspective, correct? Okay. So one thing that when I talk to patients about these CGMs is that this gives us a starting point and a direction. Where's the patient at and where are they heading? Ultimately, if they were to do like a finger poke in the moment, that data is going to lag by 15 minutes, right? So we are trying to decide how to best manage their blood sugars, especially with patients that are on basal bolus insulin therapies, that the as long as we have similar readings between the finger poke and the actual Dexcom reading on a consistent basis from what they see, then we can definitely use that data moving forward from an insulin dosing perspective. But if there is issues with regards to the way that the patient is seeing the data, like if it's erratic, if it doesn't seem like it's matching, it could be like a placement issue. A lot of patients tend to place it in like the upper part of the arm here versus underneath the arm. And if they get it into like muscle tissue, that's pretty erratic for how the blood sugars are being used. And then the other thing too is the compression lows can happen at night. So if a patient lays on that sensor and it causes that little tube to kink, it's going to cause a low that's not true. So from a low perspective, I always tell patients, you need to trust how you feel. If you are not feeling low, you need to question the reading. But I want to make sure that our patients feel as comfortable as possible. And if there are issues that they're identifying from a questioning perspective of, hey, is this accurate? Have them reach out to me so that I can walk them through it, talk about calibration specifically with the Dexcom system, and then also just making sure that they understand that the first few days of the sensor when it started tend to be the least accurate, just because they're trying to, it's little computers warming up and trying to figure things out. Sorry, hope that was helpful.
Shelby, I just want to add to that a little bit. This is the most common question that I think patients have about CGM, and they question it whether it's accurate. And so I've started putting there's a graphic. I think Libre makes a nice graphic of this train analogy. You know, it shows the caboose of the train and the engine of the train, and it shows as the train is going uphill, you know, the engine is leading and the caboose is trailing, and then as it goes downhill, it's reversed. It comes up so often. I just have it laminated in my exam rooms, and I just when this comes up, I just go over it with them, and they almost always get it immediately. As soon as you show them, they like completely understand the light bulb goes off. So that's super helpful.
I love that, Roger. Thank you so much.
Great. We had another question. Beth, would you mind coming on mute and just let us know what your role is and what your question is for Shelby?
So I'm a nurse diabetes educator at Syringa. I've worked with Shelby. Good to see you.
Hey, Beth.
I've had a couple of cases in the last year where I had people who had anemia and they had these really low A1Cs, and we were very excited about that. But when we put a CGM on them, we realized the GMI was much higher. And in particular, one of these cases is needing an elective surgery. She cannot get that operation because we have an elevated GMI. But I've also seen the inverse where I've seen elevated A1Cs that are false and really low GMIs for reasons we haven't been able to figure out. Are we starting to see surgeons take the GMI value?
You know, I can speak to that a little bit. So, one of the local orthopedists here is actually really paying close attention to those GMIs. And I've heard even payers are going to start looking at those GMIs versus, I guess, in addition to A1Cs. But as you can imagine, the GMI is based off of the blood glucose data that it is, abstracting from the patient versus trying to rely on the red blood cells, because like you said, if there's some sort of disease that is affecting those red blood cells, we can't truly trust that A1C. So that GMI can in some cases be more helpful and more accurate in those cases.